So I wanted to know whether the late onset patients in Taiwan have the IBS1 mutation as well, or do they have a unique genotype?
Thank you for asking. Currently, I have one patient have this IBS because I think previously the Netherlands came to Taiwan.
But generally, indeed, you have different mutations for the late onset population in Taiwan. Yeah? It's a Caucasian mutation.
Excellent presentations by everybody. This is, I guess, more for ONS and everything else. In your late onset patients and everything else, have you looked at any twins in your studies as far as either fraternal or identical, and has there been any differences between them as far as their lifestyles, whether they exercise more or don't exercise, etc.?
It's a very interesting question. As far as I'm aware, we do not have twins. I'm also looking at Nadine. No, we do not have twins, but we have brothers and sisters. Mm-hmm. And what we've seen is that indeed in some families where the onset of symptoms is early, you see that there is a clustering, that also in the other patients you see that there is an earlier symptoms. But it may also be very diverse, because I can also recall, for example, a family where the sister was really a sportswoman and already had symptoms quite early in life, while symptoms were postponed until 60 in the brother. So it may be also diverse in families, and maybe you recognize it here.
Do you think it makes a difference if your CK is elevated and you exercise? Does that damage more, or does it help?
Now, we have done indeed a lot of investigations, but we also have a presentation of Mark Tarnopolsky, who will address this later during the conference. So we can have a more in-depth discussion. But I think the general assumption now is that it's good to exercise. You need to exercise your muscles, because if you just sit down and you do nothing, you get atrophy of your muscles. So that's not good. So try to keep moving. Then with respect to CK, CK elevations is a characteristic of patients with Pompe's disease. Usually the CKs are higher in children than in the adults, but mostly the CKs will be in adults around up to 400, 500, 600 at max. And what we did a training study and to see whether patients could exercise 3 times a week, quite strenuous, endurance, strength, and balancing of the body. So 1.5 hour each time. And we monitored whether there was an elevation of CK, and then we dropped down a little bit. That only happened in 2 patients. And so patients with Pompe's disease can endure quite some exercise, but take care, don't overdo it, and listen to your body.
I just wanted to add another point about CK, is that we don't really go with one number. It's the trends over time that are really important, because as we've recognized in both the children and in the adults, if you have a trend towards a rising CK or a continuous increase in your urine hex4 or your AST or ALT, that is telling us that there is a trend towards the biomarkers sometimes precede, what we see as a clinical decline. So I think the points are really follow these trends to monitor your patients, to monitor yourself over time.
Yep. In Australia, we don't have newborn screening yet. But if you detect it early through newborn screening, but have been detected of genotypes that don't necessarily relate to infantile onset, what frequency do you recommend for infants or to be monitored, and how to be monitored, and how often?
So I think Nancy can speak from Taiwan and I can speak from the US perspective because we see more of the IVF supply side. There are published guidelines on this now, which was a consensus that was done with physicians from across the globe. And so I think we don't just look at a genotype and determine whether someone's going to, yes, for the infantile, we know that we want very quick follow-up and initiation of treatment. But for those who are for the rest of the spectrum, I think even as Dr. Van der Ploeg showed, there is a spectrum of involvement. And some can present early. In fact, if you look at data from the registry, there's a 12-year delay sometimes in that pediatric population of children because they went undiagnosed. And so the frequency, I think cardiac follow-up does not need to be as much in terms of echocardiograms, but good physical therapy assessments are needed. And I think in the first year of life, they should be done quite frequently, like every 3 to 6 months based on what's seen, and then the frequency can be tailored to the individual needs of that patient. So I just don't think we should say because it's late onset that we don't need to follow them closely.
But I would also add to this that if you have really the classic infantile phenotype with a cardiac hypertrophy, there should be no delay in treatment.
Okay.
You should start treatment immediately. If you have a patient with the IVS1 mutation, you have a little bit more time to think and see what happens over time. And just what I would like to mention is that it has a lot of consequences when you start treatment very early and you have a delay of symptoms until, for example, 60. So therefore you have to be sensible as a doctor and follow those patients carefully and not overreact.
May I add a comment about this topic? Because for the adults who are the future adults who are detected at birth, it's really a big issue. And I think, at least it's very important that the patient will be followed in reference center. But the problem is that if you detect at birth, there is a high risk that the patient live in another city. And if, for example, at the age of 15, he complains of muscle fatigability, mild difficulty to sport, and if a doctor decides to treat the patient, if it is not in an expert center, don't you think that there is a risk to treat without the need to treat the patient? So how to cope with this problem in the future when you will have a lot of patients detected at birth? Could you comment how you see?
Yes, that's one challenge we have. But from my experience, that currently we take care every components, the genotypes, the biomarkers, the assessment. So initially, we now know that some genotype may have less risk, and so we can increase the monitor duration, for example, every 6 months. But for some unknown genotype, we probably need to think about a typical infantile. They present some heart problem later. So at the first year, I will do every 3 months follow-up and then decide what's the risk for that babies. And again, that's because of the later onset that we don't really know asymptomatic for how many years. So currently, I take care of those babies. We ask them come back probably every year to decide if we need the treatment or not. So I think the risk for over-treatment in our situation now is not a big issue, but I'm quite sure that in other places, they may have such kind of concern.
So to come back to your question, I think we should follow up these patients regularly, and it depends a little bit on the country, but it should really be done in expert centers, like you indicated. And indeed, also every 3 months seems a good option.
I can tell you that from the first few years of newborn screening now in the United States, that my understanding, I would say, of late onset Pompe is evolving. And I think that newborn screening has allowed us an opportunity for learning for what could be earlier features of this disease that have often been missed over time. And I think the take-home message is we don't want to over-medicalize these children, but I think that we have an opportunity for good learning here. So systematic follow-up at centers with an understanding to families of not to overreact to just the diagnosis is critical.
Hello. You, in fact, have answered part of the question I was going to ask. So the newborn screening is available in Taiwan, in the States, and where else? And what do we have to do to get it available for the whole world?
We're going to leave that to our chair.
No, this is why I raise this question, because in each country, probably for most of the country, you don't have the newborn screening. Currently in France, this question was not raised since many years, and I think it will be important to do it. For example, in SMA, we know that probably we will have a large newborn screening because there is a treatment. But there is also a treatment with Pompe, so why don't we go further with neonatal screening,
Right.
with a lot of care and but even if there are unsolved questions, perhaps we should move. And this is a very
Sure.
interesting topic.
And I think the important point to make all of us appreciate is treatment does not only mean enzyme replacement treatment, it also could be physical therapy and other interventions that can help that individual or that child. And then there's also the whole family dynamics of understanding of carrier risk, etc., which goes with it. So the newborn screening program for rare diseases, I think for conditions in general, does require very good infrastructure to be able to handle it. Just giving a label is one step, and just the initial step and the baby step, no pun intended there, but it's the follow-up that needs to be well in place, and an algorithm and a systematic way that needs to be considered. And even in the States, if you look at it, each state has a different mechanism, and it needs to be thought through very carefully as it's rolled out.
So in line with that, I'd like to challenge you a bit more. So do we have signals and signs presently for preventive treatment? Because if we want to do newborn screening worldwide, we need to have something in place that is more a preventive treatment before any type of disease signs or symptoms starts. So that would be the real future for disease. Do we have signs for this?
Yeah.
Along the same lines, what do you think causes the symptoms? What's the damage? What is the degree of muscle damage which causes the symptoms? Do we have any idea?
Now, what we know is that we have too many muscles. And that we can lose quite a substantial amount of muscle tissue before we experience muscle weakness. And that's the other point, is that, but of course, and that's really a challenge, because for the future, from how much muscle do you lose before you experience muscle weakness? They say about 50% of your muscle, and then you experience, so that's quite a lot. Also, aging has an influence, so that's really a challenge. But does that address your question?
Nina, what I can share with you is that, at least in our experience, there are some who come in, and we're doing this in a formal way, where we follow them closely with speech and with feeding and swallowing, trying to understand what is the protean of manifestations that can occur. It can be very variable. And in a few of them who've undergone a muscle biopsy because they were undergoing anesthesia for other reasons, I think that's what your question is. It is interesting that the ones who've had a persistent increase in CK, the urine hex4 can still remain normal, but they can have an increasing CK and persistent increase in AST and ALT. Interestingly, when a muscle biopsy was obtained, at least in two of them, it was surprising. There was quite a lot of lysosomal glycogen. It was still primarily intralysosomal in presence, but it was there. And this was, of course, in the quadriceps that it was done.
Hey, I have a question about like carrier status. So because of newborn screening and family diagnosis, you find a lot of carriers where their enzyme level is not warrant a diagnosis of Pompe. Are you seeing a lot of symptomatic carriers, or is there discussion about symptomatic carriers and further just follow up future issues?
In my experience, symptomatic carriers do not exist. If you're a carrier, so you have to see, for example, if you have a frequency of Pompe's disease 1 in 40,000, then 1 in 100 is a carrier. So if you go to a railway station somewhere, then around you there should be lots of people with Pompe's disease. That is not the case. So if you have symptoms and you are a carrier, then there must be a second mutation. So then you're a patient. So I believe our second disease or another disease. Yeah. That is also what we've found. So I think we are convinced that carriers do not have the disease.
Hi, I'm Virginia Kimones. I have a question for Dr. Chien regarding her experience of newborn screening in Taiwan. What impact has it had on genetic counseling, prenatal testing, family planning, etc.?
Thank you for asking. Currently, we have a genetic counselor to help us to deal with that situation. So for the infantile onset Pompe disease, they tend to have prenatal testing for the planning. And for those later onset, especially for those asymptomatic, currently they don't have such kind of an action, although they know that they have the recurrence risk, but they don't have the plan to do prenatal testing.
Virginia, can add to the conundrum of newborn screening is especially with the IVS splice site, as we know there's a variable phenotype and a variable age. You often have your proband that you've picked up through newborn screening, and you've got 3 older children, out of which some are also confirmed with the diagnosis as you go through the process. And in a couple of situations where those children did have a phenotype, it was just kind of, being explored or not diagnosed. So I think it comes with, as a family package, so to say, and an extended family when you're dealing in the newborn screening setting. So the CRIM negative that I showed you, it was through newborn screening for another baby there, and that's why day 1 of life they were able to go in and treat. That was the impact of newborn screening within that family.
Excuse me, I'm at one comment that actually we have 2 families. The parents have previous affected children, infantile onset patients, but because of newborn screening, we can do earlier treatment and they see the outcome. So they decide even the affected status known prenatally, they decide to give birth and do the treatment as early as possible.
Well, so we close the session on time, and we will certainly have other questions during the break or in other session concerning the treatment and the follow-up of the patients. So thank you again for the 3 speakers. And we have a 15-minute break, I guess. Yes?